Well, good morning, everyone, and welcome to September, oh goodness, September Add Water and Stir. Hope everyone's having a great first few days of fall, I guess, officially.
I guess that's not until Monday. That'll be Labor Day, and that's the unofficial day.
Then our last few days of summer.
Yes, and if you're in California, you've got a pretty much endless summer these days. So.
Yeah, it is going to get pretty nice. But as promoted, our topic today is what to look for daily in your patients, dental signs and symptoms. So the things that you can be screening for, that your team can be screening for, that might prompt some of the sleep apnea questions that we've been talking to you all about. So I'm going to kick it off with the first sign, and that's something that is really common to see in your practice, and that's bruxism.
Yeah, absolutely. Bruxism is definitely a clinical sign to look for, but I think I want to step it back a little bit because it really all begins with soap.
Okay. Yep.
Okay. So you might ask, well, what's that all about? Well, SOAP is an acronym for a way of assessing patients. Okay?
Exactly.
And we use SOAP notes all the time in not only dental sleep medicine, but it's also a good idea to use it in your dental practice as well whenever you arrive at a diagnosis and a procedure. So, what is SOAP? Well, it starts with symptoms are subjective. Now you can have, and you should have, on your intake questionnaire questions about previous diagnosis with sleep apnea, and if you want to embellish on that, you can ask about have you ever had treatment for sleep apnea, are you using a CPAP, would you like to know about a dental alternative. Okay, so that's number one. And you've got to ask about that. Now you can then lead into a conversation about quality of your sleep, your daytime energy level, things of that sort. Do you take naps? I mean, these are all the subjective symptoms of sleep apnea. Some offices want to take it even another step further and will go ahead and administer a questionnaire like the Berlin questionnaire or the Epworth Sleepiness Scale questionnaire. Okay. Are we having a technical problem?
I think we're having a technical problem on our other feed.
Okay.
But I think we're going to plow forward here,
All right.
and we'll revisit that issue later.
Okay, all right. So we've covered that. Next is objective. Now that is the clinical signs, and those are something that you observe. Your team members, of course, can observe those too. So what are the clinical signs? Well, bruxism. Okay.
There we go.
Yeah, bruxism and sleep apnea. I call them cousins, and so those are some clinical signs. Other clinical signs: a long face, retruded chin or a short mandible, a high vaulted upper arch, posterior crossbite, a large tongue, okay? A patient who is maybe has an excessive gag reflex, gag reflex that seems excessive, that makes it very difficult for him or her to have any kind of dentistry done, in the back of the mouth. So very protective of their airways, for example. And you definitely want to observe for those. Also, of course, neck circumference is an important sign.
Absolutely.
Okay, so
that's a really easy visual risk assessment.
So if it's a man, for example, ask what collar size he wears. If it's 16 and a half or greater, high risk for obstructive sleep apnea. For a woman, that number would be about 14 and a half. You can also have some tailor tapes in the operatories. I talk about it all the time, so that you can measure something like that, for sure. Now, other objective signs would be found in the medical history.
Okay.
Okay, so what are some of the signs in the medical history that we look for?
A history of heart disease.
Heart disease. hypertension, high cholesterol, adult onset diabetes. Okay.
What about acid reflux?
There you go, GERD, acid reflux, and there may be drugs that are associated with that. So
Right.
the patient may say, no, I don't have GERD, but they're taking Plavix, or not Plavix, but they're taking one of the drugs for acid reflux. So you look for that as well. Okay, so now we've gotten through subjective and objective. Now it's, you're ready for basically to do your preliminary diagnosis. Now the preliminary diagnosis or the differential diagnosis has to be confirmed.
Yep.
How do you confirm a diagnosis of sleep apnea?
Sleep study.
The only way.
That's the only way.
The only way. Now, you start to talk to your patient at this point, and you say, okay, Bob, in fact, I had a patient yesterday, his name was Daryl. And Daryl, he told me he's a mouth breather. He's got chronic pain issues. That's another clinical sign. Okay.
We're up to 2.
Okay.
Up to 2.
Okay.
Little light bulbs going on. Hey.
Right. He's got posterior crossbite. He's had Invisalign because his teeth are all crowded. Okay. He has a high palatal vault. Salivates like crazy. His tongue, he can't control his tongue. It's moving all over the place. Gags real easily. Is a bit overweight, and he's getting close to 70 years old. Okay, so I said, look, have you ever been diagnosed with sleep apnea? And he said, well, no, I'm supposed to have a sleep study. I said, well, why haven't you done it? He said, well, I have friends that have CPAP and they all hate it. I said,
Common.
well, I'm a diplomat of the American Board of Dental Sleep Medicine, and we have, an alternative to CPAP. And did you know that it will reduce snoring, loud snoring? It reduces loud snoring in 90% of the people who get it. And his eyes kind of lit up at that point, because I said, so, tell me about that. And he said, well, I'm a mouth breather. I snore all the time. Sometimes I have to sleep in the other room. Okay, I can't sleep in the same bedroom with my wife. I said, okay, well, we need to get you a sleep study. Now, I could go a couple of different ways. I mean, one way to go would be, okay, I've got equipment. Let's send you home with my equipment for at least a preliminary screening, and that's a great way to go. And I would consider doing that if I were. Well, we have a client, for example, he's in Montana. Okay, the closest sleep doctor is over an hour drive away. So, that makes sense for him to have equipment right there. The closest sleep doctor that I work with regularly is 10 minutes away, okay, in my practice. And I'm going to want this guy to be co-managed anyway by a sleep physician. So, sure enough, gave him a referral. Okay, he even knew the sleep physician that I was first going to refer him to, and he said, my friends don't like him. Okay, I know him because I played golf with him at the country club. Okay, so I sent him to a different physician. The guy also has a history of asthma, okay, and he had a real bad bout with COVID. So, all of these things are, kind of adding up and stacking up, and we know that we can definitely help him.
Yeah.
And he needs a consultation with a pulmonologist who also happens to be board certified in sleep. So that's what I did. I gave him the referral. I really emphasized going. He was, he is acting a little bit hesitant. I did talk about the possibility of, dying in his sleep.
Yep.
And I also played the stroke card. Well, how do you play the stroke card? Well, you could die in your sleep, but more than likely something else will happen. You'll have a stroke or something like that and be the gift that keeps on giving to your family. I said, how would you like that to happen? This is serious. This is not like having a cavity that you don't get filled until it starts to hurt and maybe you have the tooth pulled out. But that problem's solved pretty easily on the scheme of things. So that's the objective, that's the subjective, that's the objective, that's the assessment that we give. And once we get that diagnosis,
Right.
then we have a plan.
Yes.
Okay, so what are the two main ways of treating sleep apnea?
CPAP,
Okay, the
gold standard.
Right.
Got to be mentioned.
Right, and then the oral appliance. So back to oral appliance. Well, let's back to the whole idea of efficacy. Okay, CPAP, when we're looking at the apnea-hypopnea index, is more efficacious than oral appliance, i.e., CPAP worn will reduce that AHI number to within normal ranges on almost everybody that gets it. Okay.
Yeah.
Oral appliance depends. Okay. To get, and we even look at a different standard. We look at the gold standard for oral appliance to get the AHI under 10. Well, for our mild to moderate patients, 80% of them will get to that level. For our severe patients, 40% will get to that level. But here's the rub. Even though CPAP is more efficacious, it's not used nearly enough. So its effectiveness is reduced because it's not used.
Yep.
The opposite stands for oral appliance therapy, and that's why it works so well. So that would be the plan. Now, it'd be okay. I mean, look, Dr. Median, who I referred my patient back to, he may do a sleep study and the results come back where he says, you better try a CPAP first. Patient might say yes, might say no. We now have at least medically and according to the guidelines through the American Academy of Sleep Medicine, Dental Sleep Medicine, even severe patients who refuse CPAP should be prescribed oral appliances. So don't despair, don't worry that your patient may not get back to you for a while for an oral appliance. If it goes with a CPAP and likes it, that's just fine because
Right.
you've made a referral. Okay.
And this is the importance of having relationships with the physicians in your community.
Right.
Something we've talked about plenty of times. Quick plug, go back to our YouTube and watch our presentation
yes,
on
please do.
building relationships with the physicians in your community. Because this is a great example. Dr. Median, if that patient says that's no way ever going to happen, I'm never going to be wearing a CPAP, what's he going to say to that patient?
He said, well, let's get Dr. Greenman to make you an oral appliance and we'll manage this condition. So
Absolutely.
Right.
Best referral you can get.
And plus, as far as I asked the patient about his primary care doctor, he said, I'm looking for a new one. I don't like my primary care doctor. I said, well, you've got asthma. You had a really bad bout with COVID. Dr. Median is a pulmonologist. He's an internal medicine specialist with a subspecialty in pulmonology and critical care pulmonology and sleep. I mean, he's got it all, and you should be. And he's my personal physician as well. So, my goal was obviously, for my patient's best interest, but it does come back to you because the best way to get referrals from sleep doctors and other doctors is refer to them.
Yep.
And keep the communication open.
Absolutely.
Okay. And that's written communication. And that's something that we, with our clients, stress, and we provide the
100%.
outline.
We'll get you set up with
we
all of
provide
that.
all the documentation, basically checklist forms that you can fax to your physician colleagues. Really, well, as close to a turnkey operation as you can have, and that's why we call it Add Water and Stir. So, Nikki, tell us what's happening next time.
Okay. Just before we part, though, those are all great things to be looking for in our patients on a daily basis, but just let's make sure that we've covered all of the bases. Dental signs that you and the team can be screening for on the daily. So we talked about bruxism, that's a strong one. We've talked about GERD. We've talked about tongue issues like tongue size, scalloping of the tongue.
Right.
These are all things that every member of the team can be keeping an eye out for. Hygiene assistance. What about your patient that often breaks their restorations?
Well, that would be a sign of clenching, grinding, bruxism. So broken restorations for sure would go into that category. You can also look for non-carious lesions, at the gingival margin. We've called them abfractions. We've called them all sorts. Toothbrush abrasion, it was called back in the day. Those are clinical signs of bruxism, and they would also be patients that are higher risk.
what about your patients that fall asleep in the dental chair and can sleep through an entire appointment?
Yeah, unless they were up nervous and worried the night before and you gave them drugs, they shouldn't fall asleep. Okay.
So all things that, again, team effort, you can all be looking for on a daily. So what's up with us? You can find us online at dentalsleepapneatraining.com. Please go on, request a complimentary consultation, talk live with myself or Dr. Greenman. We're happy to talk. If you just want to chat about what you're doing in your practice right now, we love to hear it from practices all over. Call us, pick our brains, see what we can help you with. We are happy to share. Find us on Instagram at DSM Solutions CA. You can find us on Facebook at DSM Solutions. You can shoot us an email, info@dentalsleepapneatraining.com, or give us a good old-fashioned phone call, 818-561-6715. We will see you back here the first Monday of October.
Okay, it'll be officially fall.
It'll be officially fall. We will promote our topic in the coming weeks, and we will talk to you later. Again, we do have a YouTube. Look us up, DSM Solutions. You'll find past months' presentations on a whole variety of topics. I did mention the networking with physicians topic, and that's something we talk about a lot. Really important, really, really great information. So we'll see you then.